My name is Ajay Nooka. I'm an associate professor at the Winship Cancer Institute of Emory University. I'm the chair of the myeloma working group, as well as the medical director for the Winship Research Informatics. Amyloid is a protein that is not easily soluble. It's a dissolvable protein that can deposit in various organs. So when you talk about amyloid, the amyloid that is treatable is what is called the light chain amyloid or AL amyloid. So there are several types of amyloids. There are 40 different types of amyloid, but the one that we're specifically focusing is on the AL amyloid. So when you're talking about AL amyloid, think about the disease as three different compartments. Compartment one is the bone marrow where the cells live. Compartment two is the blood. Compartment three is where you have all the organs that are affected or that have a potential to be affected. So in the bone marrow, the cells, for various reasons, this amyloid producing cell is making the undissolvable protein that is spit out into the blood. And since blood is a dynamic organ, like it circulates all the time, it is providing as a vehicle to go into the third compartment where these dissolvable amyloid proteins are deposited into various organs. What are the most common organs that are deposited in? Amyloid can involve the heart, involve the kidneys, involve the liver, involve the gut. So all these are potential places where the amyloid can be deposited. So think about this as a faucet and sink theory. Your faucet is on and it is clogging the sink. So all these amyloid fibrils are they're produced at one place, they're going into the blood and the organs and depositing at various places. So what happens untreated? So the heart is dragging on this amyloid as the natural history goes, like undiagnosed, untreated, the heart, instead of pumping, it is dragging this dead weight. And similarly, the kidneys, which are the filters, typically are not doing the function of a filter, so losing a lot of protein. So one of the things that we typically look for is about evaluating the organ functions is to look for the enzymes that the heart is releasing, how much protein the kidney is not able to preserve and you're peeing. All that will help us to evaluate about the tumor burden or the organ involvement. So now, once we have diagnosed by various methods, number one, we need to make sure that we have a clonal population in the bone marrow that is producing the amyloid. Number two, we look for the tumor burden in the amyloid, in the blood, tumor burden in the blood. Number three, we need to prove that there is an organ deposition by various methods. And there is a specific test called the congruent staining that can show that, yes, the amyloid is deposited. So once you're able to establish the diagnosis with all these aspects, you go on to what is expected from treatment for an amyloid. So the treatment, I want to be very clear here with all my patients, the treatment, when we talk about the faucet and the sink theory, the treatment is not aimed at unclogging the sink. The treatment is aimed at shutting the faucet. So, which means all the deposition of the amyloid fibrils that happened over time will not return back to normal the next day. So it takes time for that organ response. The body has the cells that will be able to get rid of this amyloid over a period of time. So I have patients that it took 2 years, 3 years, 4 years for them to regain that function. But what was very beneficial, or what is more important, is for the patients to understand that absolutely, yes, we can treat it, but the treatment is not aimed at going and dislodging all the protein that has already been deposited. There have been a trial looking at this using a monoclonal antibody to dissolve those fibrils, but the trial was not a successful study. So still, We go on with only one goal of treatment. The goal is to shut down the production of these amyloid fibrils by knocking those plasma cells that make the amyloid, and we have effective treatments to do that. There's a new study that was just published in the last year or so that was showing the addition of daratumumab, which is a monoclonal antibody, to target the CD38, which is present on these cells that make the amyloid, in combination with bortezomib, Cytoxan, and dexamethasone. The study is called the Andromeda study that had shown, but by giving these 4 drugs, you're able to get decent responses in not only controlling getting a hematological response in controlling the plasma cells not to make the amyloid, but also getting an organ response. More interesting, the key that one needs to understand is, among all the patients, if I take 100 patients, the patients that are eligible for an autologous stem cell transplant or a transplant to knock off the remaining plasma cells that make the amyloid, patients who are eligible account only for 20 to 30% of all the patients. That means these are the patients that their hearts and their organs should withstand a transplant. So one can ask, why is it so important to do a transplant? Because patients get such good long-term remissions. On an average, patients get, in our institution analysis and analysis from various other institutions, among these 50 to 100 patients that they treated over the last decades, you're able to see patients living in remission for 15 years, 20 years. Those numbers are not uncommon. So that is the advantage of doing those transplants. And there are other 70 to 80% of the people that I talked about that may not be eligible for this transplant. They would benefit from the initial induction treatment, and after 6 cycles, if they get a good response, there are some patients that might benefit from a maintenance treatment. Some people, we just continue to watch them and let the organ recovery to happen over a period of time.